As you know, there are many unmet needs in renal cell carcinoma. Although immunotherapies have revolutionized the way we treat this disease, there is still a significant proportion of patients who may not benefit from these therapies. So there's a lot of investigations going on to identify the strategies to foster immune activating effects of immune checkpoint inhibitors. And we know that immune system follows a circadian pattern. So the administration of the infusions of immunotherapies may have an impact with the outcomes and the activation of the immune system. So based on that, there have been a few retrospective analyses looking at the timing of the immunotherapy administration in a day and the outcomes, especially in lung cancer and melanoma. And there were associations between survival and the timing of immunotherapy were reported. So we wanted to investigate the same hypothesis in renal cell carcinoma here. In our study at ASCO GU 2023, we included data from metastatic renal cell carcinoma patients who received two types of immunotherapies, either the combination Nivolumab and Ipilimumab or Nivolumab monotherapy. And we divided our cohort into early time of infusion and late time of infusion based on the methodologies and previous reports in melanoma. In brief, patients who received less than 20% of their infusions after 16:30, 4:30 p.m., were assigned to early time of infusion, and then the rest were assigned to the late time of infusion group. We have seen numerical increases in response rate. In detail, we had 34.1% of patients, I have to correct that. 29.6% of patients responding to treatment in the late time of infusion versus 37% of patients responding to treatment in early time of infusion cohort. Similar numerical differences were seen in progression-free survival and overall survival, with early time of infusion cohort having a better time to treatment failure than late group. In detail, in early time of infusion group, time to treatment failure was 9.5 months versus 4.6 months in the late time of infusion group. The statistical significance wasn't seen between the groups, but the numerical increase was notable. We then went ahead and did multivariate analysis to account for several other variables may be confounding these differences. And in multivariate analysis, including gender, age, IMDC risk, and treatment type and disease histology, we found that the late time of infusion was associated with better time to treatment failure in this study. So in terms of its implications, we have seen a numerical increase and statistically significant increase in multivariate analysis in especially time to treatment failure. These are important findings at this point in terms of hypothesis generating. Given that this is retrospective analysis, we do not expect change in the practice, but these observations could inform a further prospective study, especially given that the making changes in infusion scheduling sounds practical and potentially feasible and cost-effective. And if there is promise for improving outcomes with this intervention, it would be worth to study these strategies in prospective setting. So for the future, I think our results are supportive for investigating different timing inhibitors for metastatic renal cell carcinoma.